Sometimes it takes a little while.
You don't have anything on the calendar tomorrow. All I have is nursing 102.
Right.
What is, we have tomorrow?
I did, because several people asked me this, and so let me just kind of say it for everybody so everybody will know. 104 only meets on Wednesdays. 103 only meets on Mondays. But you will have me every day because I'm helping with 102 labs. So it's not that you're having me for 103, 104. I'm just helping Miss Brown with 102. So you'll be, my class day for 104 is just on Wednesdays.
So what I'm saying is tomorrow I don't see anything for nothing but NUR 102.
Right.
Do we need to bring anything other than
No, just your basic book. Just your basic.
and don't forget about the other stuff you want to bring tomorrow.
And whatever Miss Brown told you to bring, yeah. But book-wise, only your basic book. Okay? All right. So this is Module A, and we're going to finish it today. A lot of this is terminology, so I will kind of go pretty fast through that. Does everybody have printed notes, just so I'll know how to pace myself? Okay. I will slow down. I do tend to lecture a little bit faster than Miss Brown does, so if I'm going too fast, it's not going to hurt my feelings for you to tell me to slow down. I'm working on it, but I still tend to talk pretty fast, so we'll just get started. Alright, as far as objectives for this module, we're going to discuss terms and definitions that are associated with pharmacology. Discuss sources of drug information, so where you can find that. Drug legislation, and that's kind of the boring part of this lecture. Sorry, got to cover it, so we'll just get through it. Pharmacodynamics, pharmacokinetics, and then how to read drug labels so you know when you see a drug label where to get the information that you actually need. Alright, so what is pharmacology? When we think about that, it's the study of drugs and their interactions with living systems. It comes from the Greek word pharmakon, which means medicine, which makes sense. Clinical pharmacology is the study of drugs in the human patient and in healthy volunteers. Pretty self-explanatory, okay? When we look at pharmacotherapeutics, it's the use of drugs to diagnose, prevent, treat disease or to prevent pregnancy. So what do we use as some medications to prevent pregnancy? Birth control. What are some types of birth control? Because there's a bunch of them. There's the NuvaRing. There's the implanted. There's pills. So there's topical now. So there's a lot of different types of birth control other than just the standard birth control pill that we used to think of. To diagnose things, we don't use this a lot, but we can give medications sometimes that will help diagnose patients. We use preventative measures quite a bit. Can y'all think of a way that we use medications to prevent disease? Okay. Vaccines. Think about that, vaccines. Because if you've already got high cholesterol and you're using that to treat a disease because you've already got it. Okay? But for preventative management, vaccines are used to prevent that disease in the first place. Okay? So preventative, that's going to be your vaccines and things like that. To treat, it's going to be where we spend most of our time. High blood pressure medication, cholesterol medication, that kind of thing. There's some drug characteristics that you need to be familiar with. Effectiveness. What does the word effectiveness mean to you? How it works. Make sure that it works. So that it does what it's supposed to do, right? Okay? That is the most important property of a drug. Does that make sense? If it's not effective, then why are you taking it in the first place? It doesn't work, okay? The drug elicits the response for which it is given. That's going to be your effectiveness. Most important property of a drug. What about safety? Is that important? Yes. Are drugs safe? Are all drugs completely safe?
No.
Okay? Safety refers to how does that drug affect the body systems? Is it safe to take that drug? And ideally, you would have a drug that has no harmful side effects. But anytime you turn on the TV, you know that drugs have harmful side effects. That's also what keeps the lawyers in business, apparently, because that's all that's on TV now is if you've taken Zoloft and your child was born with a birth defect. Okay? So safety is a big issue. But all drugs have some side effects. Let me give you an example of that, something that you wouldn't normally think of. Chloroseptic. Do you think chloroseptic has side effects? Have you ever thought about it? No, you just squirt it in your mouth. When I was working on a med-surg floor, I had a patient, and we always give our patients chloroseptic after they've had general anesthesia because they've been intubated and their throat's really irritated. So we leave it at the bedside and we tell them to use it. And so the family, who was bored to tears, read the insert. He said, "Did you know that chloroseptic can cause heart arrhythmias?" I said, "No, I can't say that I did." Well, that never happens, but it did happen to his mom later that night. So it does happen. So every drug has side effects. We would like for them not to, but they do. All right, selectivity. What does that mean? It's selective. So if you're given something for high blood pressure, if it was truly selective, the only effect that you would get is that it would lower your blood pressure. That would be wonderful. But does that happen? We like our drugs to be as selective as possible, meaning that it treats what it's supposed to without causing all these other effects. But let me give you an example. Narcotic pain medication. We give it for pain. It works wonderfully. But it also has some pretty nasty effects like respiratory depression, constipation, drowsiness, those kind of things. So that's a drug that's selective to a point, but there are some other things that it's going to do to the body. Is everybody with me on that? Okay. Reversible actions. What does that mean? That you could give something or you could reverse the actions of that drug. And for the most part, we can do that. Okay, most drugs we can reverse somehow. We give an antidote to completely reverse it, or we give another drug that kind of counteracts it. So let me give you an example of that. Narcotics I kind of throw up a lot because we use narcotics a lot when we're in the hospital. Does anybody know what the antidote for narcotics is? Narcan. Narcan. So that drug, if for some reason you are sensitive to that drug or you've been given too much by accident or because you took too much, then Narcan would be the drug that would reverse that action. Does that make sense? Okay. If you've got medication that speeds up the heart rate, you could give a medication such as a beta blocker to lower the heart rate. That would be another reversible action. Predictability. Okay, so if it's a high blood pressure pill, what do you predict will happen if you give it? It lowers your blood pressure. If it's a high cholesterol pill, you would expect that it would lower the cholesterol. So we like for our drugs to be predictable. It makes our job a little bit easier to know that, hey, that drug's supposed to do this, so we know what to watch out for. Okay? Predictability. That the drug does what it's supposed to do. And when we talk about therapeutic effects, what does that mean? What does therapeutic mean? Desired or good. That's what we want. So if you have a drug that has a therapeutic effect, that's what we're wanting. That's the desired effect of that medication. Okay? Do I need to slow down? Okay. Sorry, I told you I was fast. Alright, so I'm going to go back over these just to kind of reiterate it. Reversibility of the drug means that if we gave something and the patient had a reaction to it or had a pronounced response to it, that we could either reverse it or give a drug that would reverse it. Reversible actions. Predictability just means that it does what we think it's going to do. If we're given something for blood pressure, we want the blood pressure to go down if we're given an antihypertensive. And then therapeutic effects is where we want that drug to be. That's what we want that drug to do. If they're hypertensive, we give an antihypertensive. The therapeutic effect of that would be that the blood pressure is within normal range, or at least decreased. Okay? Good? All right, any questions about that slide? Side effects. No medication is completely safe or free of undesired effects. So when we give patients medication, although we're not usually the one that's prescribing it, we do have to kind of look at the risk and benefit of it. Can anybody tell me what some common side effects of medications are? Dizziness, nausea, vomiting. Dry mouth is another really common medication side effect. So when you're in clinical, I don't want to hear that a medication causes nausea and vomiting, because every one of them can. Depends on the patient. Okay? That's not one I need to know. I know it can do that. I want to know the ones that are specific to that drug. So we do have to look at the risk and benefit. When we do that, if we're giving them an antibiotic that's going to make them pick their toenails up, are they going to take it? So is that going to benefit the patient? So sometimes you have to look at what's going on, and some of the side effects can be to the point where they don't want to take them anymore. Nausea is a good example, but with your blood pressure medications that are called ACE inhibitors, which is a type of blood pressure medication, some of those can cause cough. And it gets to the point where the patient is coughing all the time, so they stop taking their medication because that's one of the side effects. So that's one of those things that we have to talk with the patient and see, how is it going on this drug? Because if they're not taking it, it's not benefiting them anymore. Okay. Adverse reactions. These are unintended, undesirable, and often unpredictable reactions. They can range from mild, which we normally just call side effects, so if they're mild, we just refer to them as side effects. Or they can be all the way up to fatal allergic reactions. So these are things that we would really like to not see happen with our drugs. Slow down a little bit. High alert medications. If you see a drug and in your drug book it'll say high alert, that means that the Institute for Safe Medication Practice has shown that it has a higher potential to harm you and it's considered high alert. Why do you think we put warnings on medication? So that you don't harm yourself, right? These medications are going to be ones that if you made a mistake could potentially kill the patient. Okay? Not that all of them couldn't, but these are ones that they've said, hey, this is really a big deal. You need to be very careful with these drugs. Can y'all think of any drugs that might be high alert? It's okay if you're not right. There's a couple that we'll go over this semester that are truly high alert drugs. Okay, maybe Accutane because of the effects. Those are going to be restricted somewhat because they are high risk and they can have some side effects. But these are going to be more like heparin. Okay? Or insulin. Because what happens if you give somebody too much insulin? Okay? Your body it's not good. Your body does need a certain level of glucose in your system to be able to function. If you deplete that, then the body does not do well with that at all. Okay? The other one would be heparin. What happens if you give somebody too much heparin? What is heparin? It's a blood thinner. Okay, so what would happen if you gave somebody too much heparin? They could bleed out. Is that a problem? Yes, that is a problem. We'll talk about heparin a lot more later, but just be aware, just as FYI, there are different strengths of heparin. There are some that are relatively dilute, that it would take massive amounts to cause a problem, and there's others that you could give 1/10 of a cc and it could cause somebody to bleed out. So there's some very different concentrations of heparin, so just be aware of that. Okay? All right, if something is toxic, what does that mean? Poisonous. Poisonous, good. So toxic effects means the degree at which something becomes poisonous in the body. The degree at which something becomes poisonous in the body. Okay. Can all drugs be toxic? At high enough levels, the vast majority, I can't really think of anything that wouldn't become toxic. All right, idiosyncratic reactions is just a big fancy word that means it did something we didn't predict or expect that drug would do. Okay? Idiosyncratic just means it did not react the way we thought it would. It didn't do what we thought it would do. And this could be either an underreaction, an overreaction, or a completely opposite reaction than we expected. So it didn't do what we thought it would do. It could be underreaction, overreaction, or a completely opposite reaction than what we thought it would do. Like, for instance, let's say that we gave somebody an antihypertensive medication. What do we predict that that drug would do? It would, antihypertensive, lower the blood pressure, okay? So if it did the opposite, then that would be an idiosyncratic reaction. If their blood pressure spiked instead of dropped, then that was an unpredictable reaction. It was something we didn't think would happen. Same thing with anti-anxiety meds. If you gave them something to calm them down and now they're climbing the walls, that was not what we thought it would do. Okay? Bioavailability. Bioavailability. It's the ability of the drug to reach systemic circulation, or to reach the bloodstream, from there to its site of reaction, or of action, if you want to call it that way.
The site of action.
Bioavailability just means how much of that drug gets to where it's supposed to go. Is that better? That's a little bit easier now. And its site of action. So basically the ability of that drug to get where it needs to go, which is the receptor site, or that site of action. It's probably an easier one. Well, I'm going to give you examples. When you give something IV, it's 100% bioavailable. 100% of that drug is in circulation and has the potential to get to where it's supposed to go. The one that it affects, your IM and sub-Q, has really good bioavailability. It's your oral. Just remember that your oral drugs are going to take the long, scenic route to get there. That's why it takes them longer to work. So the only time that we really discuss bioavailability is going to be with your oral medications. So if you're getting something orally where you were getting an IV in the hospital, your dosage may be increased because there's less of that drug actually getting to the site. Does that make sense? So you may have to increase that oral dose to get the same amount to the receptor site.
So the oral dose
It doesn't have as good bioavailability. Now some of them do. You may have an occasional oral drug that has 100% bioavailability. So that dosage would be the same. But if you had a drug that had 50% bioavailability and you were given 250 milligrams IV, how much are you going to have to give PO to get the same amount to the site? 500. Does that make sense?
I have a question.
Okay.
In your book,
Mhm.
it's telling on different methods of shooting something by now, and the sublingual, so that it absorbs
Yes.
faster.
Because it's more like a, I hate to say topical, but it absorbs more like a topical medication, so it gets to the bloodstream. It doesn't go through the GI tract and go all the way around and then go.
So the bioavailability in that situation
It's going to be swallowing.
You're talking about
Swallowing the medication, yes. Because your others are going to have pretty good bioavailability. Sublingual works really fast because it goes pretty much directly into the bloodstream from that side. So this is mainly the pills that you would swallow. Any questions about that? Does anybody need me to repeat anything? All right, allergic reaction. What is that? It's an adverse reaction. It means that your body had an overreaction to taking that medication. What are some signs that you would see with an allergic reaction? Itchy, rash, welts, that kind of thing. Okay, sometimes swelling. Good. So what's the difference between an allergic reaction and an anaphylactic reaction? Yes. Allergic reaction, when we think about just a mild allergic reaction, we're talking about the rash, the welts, that kind of thing. That would be more of a mild allergic reaction. If you're getting any kind of facial swelling, difficulty breathing, shortness of breath, wheezing, that kind of thing, that is an anaphylactic reaction, and it is a life-threatening emergency. Okay? Does anybody in here have anaphylaxis to anything in particular? good thing to know. Aspirin?
Naldicon.
What is that?
It's a drug that they use to stop anaphylactic shock sometimes.
Oh, well, there you go. And we do have patients that have allergies to Benadryl, believe it or not. Okay? Bumblebees. Yeah. My husband, I know I'm going to tell y'all stories, and y'all probably don't care to hear some of these, but, you know, I have a very interesting life. What can I say? My husband has allergies to a lot of different things, but one of them is to horses, which we had up until a few months ago. I didn't realize how bad it was. He didn't really say much about it, but he came in, several days in a row. He's like, I'm like, are you having trouble breathing? And he's like, I don't know, my throat just kind of feels scratchy. We don't have an EpiPen at my house, by the way. We did get one after that weekend. But yeah, anaphylactic reaction, anything that's respiratory. Somebody else have any on that? Sulfa drugs, yeah. Penicillin's another one that a lot of people have allergies to. How many people in here have an allergy to penicillin? I also have an allergy to penicillin. All right.
What does sulfur do to you? Like, it messes with my liver. It, like, jaundice gets to you.
My mom told me I've been allergic to sulfur all my life.
Yeah, a lot of times that's what we get. It's like, I don't know, my mom says I'm allergic to blah, blah, blah. And that's what my mom told me. You're allergic to penicillin? I'm like, yeah, okay. Well, in labor and delivery, we use penicillin a lot for our prophylactic antibiotic treatment. And one day I was spiking a bag, and I got some on my hand, and my hand immediately broke out. And I was like, still allergic to penicillin. Okay, Mommy's right.
I'm going to a lot of people have anaphylactic reactions to certain foods like
Peanuts. Yep, shellfish is and do y'all know of something in the medical field that we use that's akin to shellfish? If they have a shellfish allergy, you need to be careful. Betadine. So when you're asking about prepping somebody for a procedure that you're going to use betadine, you don't just ask them if they're allergic to betadine, because a lot of times they don't know if they are, but you do ask them if they're allergic to shellfish, because they could have a reaction to it. Shrimp, yeah. So that's something, and a lot of the dyes that we use have an iodine component to it. So you need to make sure you ask that. It's an important question.
I know somebody that's allergic to onions.
Onions?
Never heard that before. Who's the teacher?
My mother-in-law had surgery, and she works in surgery, and she'd never had problems with latex. But after she had her surgery, she developed a latex allergy and an allergy to bananas, because sometimes they'll develop an allergy to bananas and latex. Those are kind of kin for some reason. So, I don't know, but she just said commonly that if you're allergic to latex or bananas, you're going to have a problem with the other one. I'm not sure why. I don't know.
There is it's an enzyme in iodine.
Well, there you go.
It's an enzyme.
Y'all would listen.
But it needs to be dissolved. If you cook it,
It deletes that enzyme. Alright, so when do you think we see allergic reactions? After the first dose? It's not usually after the first dose. So when we start an antibiotic in the hospital, we always watch the second dose is usually a lot of times when you'll get a reaction. Because the body has enough of it in its system and it's going to cause a reaction. So don't just think just because you took a drug one time that you're not allergic to it. So see how you do with the second and third dose, because sometimes you won't see a reaction until you get that second or third dose. Okay?
patients can sometimes have like a delayed reaction.
They can. And in the doctor's office, we keep them there for about 30 minutes after we give them something to make sure they're not going to have an immediate reaction. But they still need to be told to watch themselves for the next 24 hours to make sure that they're not going to have a delayed reaction from that.
I know when they're giving H1N1
Mhm.
food, they have a whole lot of people that do
Mhm.
and just use a regular food shot.
Because it has, I forget which one it is, but a lot of your vaccines are made with eggs and sometimes they have a horse component into them too. So you have to be careful about, do what? Eggs. So you just got to be careful when you're looking at can they have that. And if you read the insert in your vaccine, it's going to tell you if they have an allergy to eggs that they don't need to take the vaccine. So. Okay. So tell me again, what are some signs and symptoms of anaphylactic reaction?
facial swelling.
Okay, usually I say anything that's from here up, I consider anaphylactic. If they start having facial swelling, it may have just been that, let me give you an example. My best friend's little girl can't eat green apples. She can eat red apples, she can eat yellow apples, but there's something about Granny Smith apples that causes her lips to swell. So, of course, we didn't give her any more because the next time she might actually have a true, hey, I can't breathe reaction to that, okay? So usually I say anything from here up, you're definitely not getting that drug ever again. Okay? Or you shouldn't be anyway. Any other question? Comment? Okay.
Also, anaphylactic shock, your blood pressure drops and the heart rate goes.
Yes. Yeah. And we'll talk about, you actually won't get shock until the last semester, but yes, you definitely do. Your blood pressure starts to bottom out, your heart rate goes up. Which one do you think happens first?
Heart rate.
The body tries to compensate, but then if you don't fix the issue, then your blood pressure's going to drop. What does wheezing sound like? I know we haven't even met for health assessment, but some of y'all probably know if you have a child with asthma or something. It's kind of musical, kind of high-pitched, has a special tone to it. A lot of times with anaphylaxis, you'll hear that wheezing because those airways are swollen, and that's what's causing the problem. Okay, if a patient reports they do have an allergic reaction, it's always important to ask them what kind of reaction they had. Why do you think we ask them what kind of reaction? So you can determine what the reaction was so you'll know what your treatment is. Okay? If they had a true anaphylactic reaction, are they going to get that drug? If they had a rash, are they going to get that drug? Probably not. Okay? I've only seen that where we've actually brought a patient in and tried to desensitize them to that medication because that's what they needed. So usually if it's a rash or it's anything respiratory or from here up, they don't get the drug. What if they tell you they're allergic to it because it causes them to be sick? That's a side effect of the medication. So a lot of times patients will come in and say, well, I'm allergic to erythromycin. And you say, well, what does it do to you? And they say, well, it makes me sick to my stomach. Okay, that's fine. Are we going to give them that drug? Not if we can help it, but if that's the drug that we need to give them, then we know we could probably give them something for the nausea and they could take that medication. So are you with me on that? So always ask them what kind of reaction they have. And always ask them more than once what they're allergic to. When somebody comes in from a car wreck, do you really think that they're in their right mind to tell you all they're allergic to? So a good habit to get into is when you go to give a drug, let's say it's the first time you go in that patient's room. You say, Mr. Smith, what are you allergic to? And he says, penicillin. Okay? Now you may go in Mr. Smith's room 10 times during the course of that day to give him medication. And every time you go in, he's going to think you're a lunatic if you say, now what are you allergic to? And he goes, well, I've already told you 8 times. Can you not remember? So the next time you go in, you could say, so you're just allergic to penicillin, right? It acknowledges that you do remember that he has the allergy, but it gives him an opportunity to say, well, you know what? I think I might be allergic to blah, blah, blah. Okay? So always ask them about their allergies. We talked about penicillin allergies. Penicillin's kind of special. If you have a penicillin allergy, you are more likely to have a cephalosporin allergy, which is a different type of antibiotic. So we usually ask our patients. It doesn't mean they can't get that cephalosporin. It just means we need to be on the lookout for a reaction. So if the patient had a true anaphylactic reaction to penicillin, then we need to be very careful with giving them cephalosporins.
Can you throw out the penicillin
Allergy? I'm not going to say never, because in nursing you'll learn that there's very rarely an always or never situation. Not likely. If it's a true allergy, you're probably going to have that allergy.
When I had an episode when I was younger in church, which they was all Pentecostal, so they just didn't even know. But anyways, I went to the doctor not too long ago. They couldn't give me penicillin, but they gave me moxicillin or something else, and they made me wait in the room for 15 minutes to make sure I wasn't going to throw. But I was okay with that, so I just wondered if I grew out of it. Or if it was because it was a different.
Because amoxicillin is a type of penicillin, and typically we don't do that. It just makes me wonder if maybe when you had that reaction as a child, if you were on 2 drugs, and maybe it wasn't the penicillin, it was the other drug. I don't know. Now, I will tell you, I had a allergy when I was younger to a certain dye that they used in Tylenol. And I don't like liquid Tylenol. I don't know if they've changed the dye, but I mean, it doesn't bother me now. Not that I take liquid Tylenol a lot, but it doesn't bother me when I take it. So I don't know. Maybe they've changed the components slightly.
So what is the other, if you're allergic to penicillin?
Cephalosporins is a type of antibiotic. Sure. Ceplosporins, I think. Spelling is not my strong suit. But it's a type of antibiotics. Ncef is a cephalosporin. We use it a lot for like post-op and pre-op. Okay. What does the word tolerance mean to you? What you can handle. What you can handle. Okay. When we're talking about tolerance as it relates to medication, and it can happen with a lot of different drugs, but typically we think of it with pain medication. So if you've got a patient that has, let's say, chronic back pain, and they take OxyContin, which is a long-acting narcotic, and they take that every day, and they've taken it for 6 years, their body becomes tolerant to that medication. So what you may see is that they gradually have to increase their dosage to get the same effect. So tolerance is usually going to take a while to happen, but the body almost becomes slightly resistant to that medication. So it requires higher dosing to get the same effect. And it plays an important role when you have those patients come into the hospital, especially for surgery, because they're tolerant to the medication. They may require more pain medication than somebody else would. And a lot of times nurses don't understand that. They're like, well, I gave them 5 milligrams of morphine, why is it not working? Well, if they're very tolerant to that type of medication, it may take a large dose to get them comfortable. Okay? Yes? Are they good? OxyContin, I love OxyContin. I mean, I don't personally love OxyContin, but I love it for the patients that use it. I know there's some issues with it. I know it's one of the ones that's abused a lot. But for the patients with that chronic back pain that can't get out of bed and can't function, it works really well. But with everything, there's always a flip side of that. But it is a good pain control medication. Now, the dependence and that kind of thing on it's another issue. But okay. So let's talk about dependence. There's 2 types of dependence. There's a psychological dependence, which we typically think of as the addiction, where the patient craves that medication for the effect that it gives them, such as marijuana to relax. They crave that reaction that they get to it. And there's also physical dependence, which will manifest as physical disturbances if the medication is withdrawn. And which one do you think that we see that with a lot? You can see it with any of them, but alcohol is a lot what we'll see in the hospital. Do patients tell you that they're alcoholic? When do you think you're going to figure out that they're probably alcoholic if they're in the hospital? When they start going through DT, which takes about how long? 24 to 48 hours, somewhere around there, depending on how heavy of a drinker they are. I hate to say this, but I'm going to tell you because of some personal experience, this is what I've seen. When you have patients that come into the hospital and they say they smoke a pack of cigarettes a day, it's probably more, okay? If they say they drink a 6-pack of beer a day, it might be more. So you need to, when we do our health history and our questionnaire, that's part of the things that we ask is, do you smoke or do you drink? Because we need to be aware of that. If we identify somebody, and some people are brutally honest, they'll come in and say, well, I smoked a joint last night, and I did some crack this weekend, but I don't have any money to get. I mean, some of them are brutally honest. So you just say, okay, let me just put that down and keep on going. But it gives you, at least you know what you're getting into. You know what you can do for that patient. And most of your hospitals, or I would say all of your hospitals, if we identify somebody that comes in and they're alcoholic, we will go ahead and put them on medication to help calm them down so that we wean them off of that instead of just throwing them in on day 2 with DTs. Okay. Do you think babies that are born to moms who do crack, do you think they're addicted?
Yes.
Okay. When you start talking about cocaine and stuff like that, the antidote to cocaine use, or what will reverse those effects, is Narcan as well. So for moms that come in and we think they may be cocaine users, if that baby comes out really sleepy, a lot of times our drug of choice is Narcan because it's usually related to something mom took during labor, that kind of thing. But those babies can't get that because it's like taking that newborn and saying, well, here's your DTs in about 2 seconds. So, another one of my pet peeves, but here we go. All right. Medication interactions, what does that mean? It means those medications or those two things together changes. It changes one or the other. Like, for instance, does anybody have a family member that's on Coumadin?
My mom.
Okay. What do they tell them to use sparingly in their diet? Y'all know? Green leafy vegetables. Because the antidote to Coumadin is vitamin K, which is found in green leafy vegetables. Okay? So that would be a food interaction with Coumadin. And sometimes it's not a negative, it could actually potentiate that drug. So it could be up or down. Okay?
I'm sorry, you said two drugs together
that change how one or both of the things react. Like, for instance, the Coumadin and the vitamin K or the green leafy vegetables. So it could either decrease the effectiveness of that drug or one of those drugs. It could increase that effectiveness of one drug. So it could go up or down.
One, I think, I can't think the name of the drug, but I know you can't eat breakfast and use it.
A lot of your lipid-lowering agents you can't use. Usually, I just tell patients not to. I mean, I don't know why you want to take. I like grapefruit juice, but I don't know why you want to take medication with grapefruit juice. But I usually just tell them no grapefruit juice with their meds, just because some of them can interact. Do what now? Iron pills usually you take with vitamin C because it helps the absorption. So we usually tell you to take it with orange juice because that's a high source of vitamin C. It constipates you. Yeah. Yeah. That's because the iron constipates you. It's terrible. Okay, let's see. So I talked about that it could increase or decrease. The big fancy word for increase would be potentiate. So it potentiates the effect of that drug. And the big fancy word, not too fancy, it would be diminished if it decreases the effectiveness. So you may see that wording. So with your drug interactions, you could either have a potentiated effect or a diminished effect, depending on what the combination is. Potentiated. I know, see, I'm expanding your vocabulary. Diminished. So potentiate is going to mean that it's going to increase the effectiveness of that drug, and then diminish is going to mean it's going to decrease the effectiveness of that drug. Your dairy products, like milk, sometimes can interact with medication, so we'll tell you to don't take it with antacids or with milk products.
Someone has kidney transplant, they were told not to eat milk.
Yep. And I will tell y'all, because I know y'all probably stressed out after looking at that drug list yesterday. My goal for you when you leave this class is that you understand what those drugs are and what your role is in giving those drugs. I do not test really heavy on interactions unless I stress it in class, because I think that's why, thank goodness, we have a drug book, because you're never going to remember all the interactions. But I do expect that you remember the important side effects and what your role is in that medication, what you're going to look for, what you're going to teach the patient, that kind of thing. So when we start studying drugs, just be aware that I don't test really heavily on interactions. If it is an interaction that I'm going to test you on, it will be on the PowerPoint and we will discuss it in class. Okay. All right, synergistic reaction. This is another one of those big fancy words that just means if you give those two drugs together, they have a bigger effect. They potentiate each other. And there's definitely some value in having drugs that are synergistic to each other. So synergistic just means if you give those two drugs together, they potentiate each other. You have an increased effect. Both of them work better.
Like, is it Tylenol and Advil that you're supposed to mix?
We do sometimes.
Ibuprofen or something from either one
Yeah, and a lot of times, we'll tell parents to rotate those out because they do the same thing, but giving them together has a bigger effect. Another combination that we use a lot in the hospital is Demerol and Phenergan. Demerol's for pain, Phenergan's for nausea. It's a good drug. We don't use it as much as we used to, but we do use it some.
I thought they said they was, I think before I left the hospital, a couple of months back, they were talking about taking Demerol off.
Haven't heard that Demerol's come off yet. Darvocet has. Darvocet's no longer on the market.
They were talking about Demerol too, because some lady died in the hospital, it blowed her heart.
Now, we were devastated when Darvocet came off the market because we used Darvocet as was our go-to drug at the hospital, but we got to ensure safety. So, all right. So Demerol is a narcotic. Phenergan is for nausea. If you give them together, then the pain relief is better and the nausea relief is better. So they work together very, very well. And Demerol does have a pretty nasty side effect that it can cause nausea in a lot of people. So giving those two together is the best of both worlds.
So are synergistic reaction to the good thing?
For the most part, it is. It means that they work better together. Okay?
I'm sorry, what was that? Demerol and what?
Phenergan. And it's okay if y'all don't spell it right. Half the time I won't spell it right. All right, 98,000 people die each year from medical errors that occur in the hospital. More people die from this than MBAs, breast cancer, AIDS, and workplace injuries. So it's a big deal. Motor vehicle accident, sorry. So if you see MVA, that's motor vehicle accident. So it's a big deal. So when we talk about how the process for giving drugs and that kind of thing, I'm very strict that you do every step because that's what's going to keep you from making a mistake. If any nurse tells you they've never made a medication error, they're probably lying or they didn't know that they made it in the first place. Okay? I have made a medication error. Did it harm the patient? No. Did it make me sick to my stomach? Yes. Okay? It was Plavix, which is an antiplatelet agent. I didn't catch it, and the night shift nurse did. I gave her a whole tablet instead of half a tablet. And so when she said the day shift nurse gave me a whole tablet, so I came in the next morning, and I was like, oh, my God, yeah. I gave her a whole tablet. And the doctor's like, well, it's fine. She probably needed the whole tablet. But it was still a medication error. Could it have harmed the patient? Yeah, it could have. So you got to be very, very careful. Even when you get really busy, you still have to go through all those steps. Okay? The night shift nurse had because she's the one that called it. So. And usually, the big thing that I need to tell y'all from any kind of experience in the hospital is own up to your mistakes. There's very few things that you can do that I can't fix, but if you don't tell me, I can't fix it. There's very few things that you can do that in the hospital we can't fix. If you give too much insulin, which is not going to happen, this is going to be double checked, but let's say by some chance too much insulin was given, there's medications that we can give to reverse that. But if you keep your mouth shut and the patient's blood sugar bottoms out, then they could have harm from that. Does that make sense? So always own up to it. And to promote that, most of your hospitals have a policy where if you report it, you usually don't get in trouble for it. They want you to report it so that they can make changes to the policy to make sure it doesn't happen again. And insulin is one of those drugs that even when you're licensed, you have to have a second person check you off on. Now in school, I am your second person. There's two of us. But when you get out, you still have to have a nurse. All right, because of this, JCO, is everybody familiar with JCO? Joint Commission is the accrediting body for the hospitals. In 2002, they implemented safety goals that are updated each year. So what they do is they look at the hospitals and they say, okay, these are the problems that we've identified over the past year. These are the safety goals for the next year, and every hospital has to be compliant within these safety goals.
So because of medical errors?
Because of medical errors. Okay, or just trends that they're seeing. So as far as medication, I was trying to think this morning of the ones that we do in the hospital that are new. We require that every patient that comes in the hospital, their medications have to be reconciled, meaning that we look at their home medications and we make sure that the physician looks at them. He says whether or not he wants them continued in the hospital, Before they go home, that list is printed back out. There's specific instructions so that it's continuous, that these are the medications that you are currently on. These are the ones that have been discontinued. These are your new prescriptions. This copy needs to go to your primary physician so they know exactly what you're on. So that's one of the things. The other one is medication errors, and that's going to be identifying the patient. So we use 2 identifiers to identify a patient, and we don't just use name or room number. We have to use something, name is one, but then you have to use some kind of supplemental identifier. So in the hospital, you're lucky because you have an armband, and it has their medical record number and their account number on it, and those are specific to that patient. Safe and accurate administration of medications is one of the nurse's most important responsibilities. I think we've already been over that. Medications are available in many forms. It is still a medication error if you give the right medicine but the wrong route. So if it was supposed to be given IV and you gave it IM, that's a medication error. Some medications are available in several different forms, and it's important that the patient receive the right medication in the right route. And we're going to talk about that in just a few minutes. We talked about Phenergan, that was for what? Nausea. Do y'all know how we give Phenergan? Okay. You can actually give Phenergan PO, which is by mouth. There's your abbreviation. PO is by mouth. Okay. IV is intravenous through the vein. You can give it IM, which is intermuscularly. You can give it PR, which is per rectum. You can also give it topically. So all kinds. Okay. I've never really understood if you're puking up your toenails how you're going to keep a pill down. So we use the suppositories a lot. We use the topical. I love the topical. It's a little gel. You just stick it on the wrist. They rub it in.
My wife's doing that
For pregnancy. Love topical Phenergan. You ever tried to hold your child down and put a suppository in them? They'll hold their wrists, and you'll be like, "Ooh, yes, that's great." But you try to put a suppository in, and oh no, my girl was pretty rough too. All right, you do need to commit these to memory. These are the 6 rights that we check before we give any medication, so we're going to go through those. The right patient is pretty self-explanatory. It is really important that you give the medication to the right patient in the first place. So we're going to check their name, their medical record number, their account number, and their date of birth. Name, medical record number, account number, and date of birth. Because you could potentially have 2 Miss Smiths in the hospital on the same floor. So we need to make sure that we're giving this Miss Smith's medication to her and choose the right Miss Smith. So name, account number, medical record number, and birthday. You cannot use room numbers as your identifier, because we do have some hospitals that are still semi-private, so you could be in the right room but still have the wrong patient. And you could have patients that know each other that go in each other's rooms. So you can't just use the room number as the identifier.
Name, account number, medical number, date of birth?
Yes. Name, account number, medical record number, and date of birth. Right dose. What does that mean? The right amount. The right amount. So when we start talking about drug calculations, that's where that comes in. I need to know that you understand how to give that patient 250 milligrams. So the right amount, the right dose. The right route, which we've already talked about. There's several different types of medications that can be given in several different routes. You have to give it in the one that's ordered. And sometimes the physician may give you some leniency on that. He may say you can give that Phenergan IV or IM, and that's fine. You could use either one of those routes. But if he only ordered it IV and you gave it IM, that would be a medication error. If he gave you the option of either one, then you're fine. Okay.
So we can't give IV.
Y'all can't do IV pushes, no. Okay. Not in Alabama anyway. All right, right time. What does that mean? Okay, they're on schedule, so let's talk about that for a minute. A lot of times, what does TID mean? Okay. What does Q8 hours mean? Isn't that the same amount? Isn't there 3 sets of Q8 hours in 24 hours? It's not the same. You're right. Let me tell you why. Let's say you had cough medicine, and he said give it TID. Then we would give that 3 times a day while the patient's awake. Okay? But if that physician said give that ANSEF Q8 hours, you give it every 8 hours around the clock. Does that make sense? So BID means what? Q12 hours means literally every 12 hours. QID is 4 times a day, which would be what? Q6 hours? Q6 hours. Okay? So if it's ordered per, Q4 hours, Q6 hours, that means around the clock, every 4 hours regardless. If it's TID, BID, QID, then you do those time frames are staggered so that they're while the patient's awake. Because I'd be really ticked off if you came in to give me some cough medicine and I was asleep.
What did you say,
BID. Like B is in ball. 2 times a day.
We have all this stuff in the list, right?
It should be. You should have all of those. But just kind of, I usually try in class to go ahead and start popping those at you because I think the more you hear them, the easier it's going to get for you. So I'm not going to cut you any slack and not use the abbreviations. I'll tell you what they are the first time, but after this, I'm just going to say BID, and you're like, okay, you write that down and you go back and look at that so that you can start committing it to memory. Okay? All right. Some other things that you may see are on-call medications. That would be a certain time frame. So what happens is with those, most of the time it's on call for some type of procedure. Like you might give an antibiotic before they go to surgery. And we don't really know when they're going to surgery. So when they call and say, hey, we're fixing to come and get them, you go in and hand those medications. You may see that. Stat would be, and I will tell you, typically we don't have orders that are typed up that say stat, because usually if it's something that's stat, it's going to be a verbal order, and you're going to have to write it after you give the medication, because it's an emergency. After meals, do y'all know what the abbreviation is for after meals? PC. So if a medication's after meals, it'll say PC. It's probably Latin. A lot of the abbreviations are Latin. Yeah. PC is after meals. What's before meals? AC. AC is before meals. PC is after meals. What's at bedtime? HS. Hour of sleep. Okay? We use it sometimes in our documentation for like shortness of breath.
Yeah.
It doesn't stand for the other thing that we think of. However, if you read some notes, it might sound like that's what they were trying to say. But no, usually I'll try to describe it more than just short of breath. I'll say dyspneic, which means they're short of breath. That way there's no confusing.
Are them in the 102?
They should be in the 102 syllabus, that long list, like that 3-page list, it should be in there. Alright, as far as time frames, if it's just a blood pressure pill, I hate to say just because it's very important, but if it's a scheduled medication, and let's say that at West Georgia we use 10 o'clock as our standard morning time to give meds, then you have some time, a little bit of leniency on those. So if it's a blood pressure pill that's due at 10, textbook says you've got 30 minutes on each side of that time frame to give that drug. So for instance, if you had a medication at 9 and 10, you might give both of them at 9:30. Because you're giving one 30 minutes early and one 30 minutes late. So that would be fine. So you do have a 30-minute window for scheduled meds. But if it's antibiotics, you need to get them hung as close to time as you can because we're wanting those blood levels to be constant for those medications. Okay? What does PRN mean? As needed. There's another one of your abbreviations. So if you've got Demerol, Q4 hours PRN, that means as the patient needs it. If the patient needs it and it's been 2 hours, can you give it? No. It has to meet the parameters of the time frame. They can want it all they want to, but if it's only been 10 minutes since you gave it, you can't give it again.
So if it's every 4 hours and you said PRN
Mhm.
meeting. So it don't make any sense because if they can't have it before 4 hours to go, why isn't it asking?
Well, because if he just wanted them to have it every 4 hours, he'd say Q4 hours. Because you don't want to go in there and give somebody something for pain if they're not hurting.
Also, let's just say they didn't want them before hours, maybe they had that opportunity.
Right,
Okay.
right. PRN just means that the patient requests that medication. So usually the ones that you'll see PRN is going to be your nausea medications, your pain medications, that kind of thing. The ones that if the patient starts hurting, we'll give, but they request them.
Does the patient always have to request PRN medication? Or you can make that choice?
I don't just go in there and give them something, but I will say, do you want something for pain? Or are you hurting? Because you've got,
What about agitation?
I'm not going to say I've never given pain medication for agitation. But a lot of times their agitation was causing them to hurt. Because they couldn't be still, so now they're hurting because they're not being still, so it kind of killed two birds with one stone kind of thing. And a lot of times the physicians will give them anti-anxiety medications, PRN, if they need those as well.
Oh, that's my question. The patient, you say, hey, you feel a little anxious, whatever, goes on, I'm fine, and they're bouncing off the wall. Can you make that call and get it in? They have to verbally ask you for it.
I'm going to go with textbook answer of yes. They have to verbally ask for it. Okay? And I will tell you, sometimes it's a tough call because you have a lot of different scenarios when you're in the hospital. You have your older generation who could probably have their leg chopped off and they would rate their pain a 2. And then you have the younger generation that come in not in labor, cramping, that go, oh my God, it's a 10. Yeah, girl, let me call you back. Yeah, I'll call you right back. Okay? 2 ends of the spectrum. The Joint Commission says what they say their pain is what it is. So if that girl rates it a 10, it's 10. You might say, patient rates pain 10, but talking on phone with no facial grimacing. Okay? That's how you would document that. You're still giving her credit for her 10. You're just saying she's on the phone. And she's, okay? You got to document what you see. All right? So there's definitely, and then there's always the family. The patient's got a PCA pump, which is a patient-controlled analgesic pump, and they're like mashing the button. And the patient's like, and that's when you go, okay, the only person that gets to mash the button is the patient. If the patient can't wake up to mash the button, the patient doesn't need the medication in the first place, okay? So you have all different spectrums. Or you'll have a patient's family that says, he needs something for pain, and the patient's going, I'm fine. Now, he really's got to have something for pain. I mean, you're thinking, okay, you need something. You need something to relax, because he's fine. So you do have to take each situation and deal with it appropriately. Okay? Alrighty. Make sure I've covered all of my things. Right drug, I think that one goes without saying. It's very important that, if you're supposed to be giving Tylenol, that you didn't give them Coumadin. That would be important. And then the right documentation. In nursing school, if Ms. Brown hasn't told you this already, you're probably going to hear it 5 million times between now and the time you get out of first semester. If you don't chart it, you didn't do it. Okay? If you don't chart it, you did not do it. Because a lot of times mistakes are made because nurses didn't keep their paperwork up. For instance, with medications. Let's say that you are swamped, and you went in Ms. Smith's room and you gave her medication, but you didn't chart it. Well, your charge nurse, being nice, said, well, I'm going to go catch her medications up, and went back to Ms. Smith's room and gave her the medication again. So if you didn't document it, she has no way of knowing that it was done.
Can you chart immediately after the disease?
Yes. Especially with medications. And most of your hospitals now are on computer system, so all you got to do is take your little, pad here to the room, check it off, and mash a button, and it charts that, hey, these medications have been given. So it's a lot more simplified now that it's on the computer. So yes, most definitely. And my biggest advice for you about documentation is keep it up to date. If you sit down during your clinical day at 2 o'clock in the afternoon to chart everything that you've done for your, let's say you're in last semester, for your 5 patients that day, they all run together. And you're going to leave out some stuff that had you kept your charting up to date, you probably would have remembered to put in. If you're charting at the end of the day, you're just hitting the high points.
What would keep you from not doing it? Well, why would you wait?
Well, let's say I can tell you in labor and delivery, if you got a baby crowning, the documentation waits. But I will also tell you, I can't tell you the exact second that I can't chart real time when I go back and do it. You know, I'm just going to have to say, okay, at this time I did these 3 things. So usually it's patient load, that you're just really busy. And a lot of times with nurses, it's a bad habit that they got into. They just put it off. Don't get in that habit. Start immediately doing your charting as you go, so that when you start adding patients in the subsequent semesters, that you're in that mindset of got to chart it, got to chart it. And a lot of times you'll see nurses, what we'll do is if we know we don't have time to write that whole note, this is what you'll see when you get back to the nursing station. There's a napkin, there's a napkin, there's a napkin. Okay, 9:05. So they take the napkin out of the room, write their little thing, stick it in their pocket, so when they go back they can chart it.
You can do that?
It's not the best thing, especially now with computerized, you should just be able to type it in. But yes, if patient care is going to be compromised for you to write that note, like in a code situation, you're going to go, hold up, stop chest compression so I can chart this. I mean, you know, so you do the patient care and then you chart it. It doesn't have to be the exact second that you went in there, but you want to chart it immediately after. Do what?
Sometimes you only choose a good charter.
Well, and usually that's what we do. In a true high-stress situation like a code or like a delivery where we're having a nurse having to do the delivery, it's not like you don't have other people in there. And so that's one of your assignments is you chart. That's your job. So you chart while everybody else is working so that it is appropriate. Okay.
And I also know that a lot of hospitals got meetings with joint commissions about this.
About charting. Well, and I will say, I do think the computers are a great thing, but they're also, everything is transparent, everything's real time, so I think there's probably always been those issues with documentation, but now that it's on computer and you can see the trail, it's just more apparent. I think there's always been issues with it, it's just more obvious now. Okay, it is 12:08, is that correct? Is that what y'all have?
It's somewhere in there. Yeah.
All right, I'm going to get through a couple of these drug legislations so we don't have to be completely bored when we come back from lunch. All right, drug legislation. And these are what they are. We're going to get through them. You know, I don't know if you're going to ask. I don't think when you get out to work, somebody's going to say, well, can you tell me what the Pure Food and Drug Act was? But we're going to cover them. All right, 1906, the Pure Food and Drug Act was established. It did not address drug safety or effectiveness. It didn't really do much of anything. Okay. In 1938, the Food, Drug, and Cosmetic Act was the first legislation to regulate drug safety, although it wasn't exactly stringent, but it was better. It was established because more than 100 people died after taking an antibiotic that contained diethylene glycol, which is an antifreeze. Okay. This did lead to drugs being reviewed by the FDA, which is the process that's in place now, even though it's a little more stringent. All right, the Durham-Humphrey Amendment to the Food, Drug, Cosmetic Act was established in 1952. 1952? I'm sorry, it's 52. No, it is 62. It is 62. I have it wrong on mine. All right, determine which drugs could be sold with or without a prescription. Also determine which drugs should not be refilled without a new prescription. So which drugs could be filled with or without a prescription, and which drugs would require a new prescription to get a refill. 1962.
What?
The Durham-Humphrey, that's what we're talking about now. 1962. Determine which drugs could be given with or without a prescription, and which drugs would require a new prescription before they could be filled. Why do you think this came into play? Drug abuse. Because if you gave somebody 20 tablets of, let's just say, OxyContin with 5 refills, then there's no regulation to see is that patient taking that medication appropriately, are they being evaluated to see if it's effective, all that stuff. I'm going to check that date. Just circle that, let me check it, because it may be 52. Because I know this one was in 1962. All right, Harris-Coffer amendments to the Food, Drug, and Cosmetic Act was established in 1962. Required proof of effectiveness before a drug should be marketed. It was the first law to demand that drugs actually have some benefit, which is amazing. Okay. Everybody know that? Okay. It did tighten the controls on drug safety. It ensured that the contraindications were actually in the literature that was with the drug. And contraindications are reasons that you would not give that medication. Like, for instance, it would be contraindicated to give heparin for somebody who is actively bleeding from an MVA. So contraindication means that's why you would not give that drug.
Then you said it was printed on the drug.
That it was in the literature with the drug that the contraindications were there. It also instituted the process for withdrawal of a medication once it was already in the marketplace. So like with Darvocet, there's a process of how to pull that drug off the market after it's been given. It was created in response to many pregnant English women taking the sedative thalidomide, which caused their infants to be born without arms and legs. It was not a problem here in the United States, but we did have some legislation to ensure that it didn't happen here. It established those rigorous procedures that we know to ensure the safety of drugs. One more. Y'all with me, or do I need to go back? Your notes are backwards.
You said insurance contraindications were printed on the drug and instituted the process for withdrawal of the drug off the market.
Yes.
So those are all two.
Yeah, pretty much.
Okay.
Other than what's already in there. Okay. All right, Nurse Practice Acts. These are guidelines that are present in all 50 states and the District of Columbia to help ensure safe practice and prevent unskilled workers from practicing. Basically, this is your scope of practice. It says what you can and can't do. It's the reason that an RN can do some things, an LPN can do some things, a CNA can do some things, but Joe Blow off the street can't come in and give an injection. Okay? A lot of these do include areas of medication administration, and when we go through the curriculum, you will hear us talk about things that LPNs can do. What's the LPN role? What's the nurse's role? What's the CNA role? And we'll try to bring some of those in, but all that's going to refer back to the Nurse Practice Act. Like, for instance, as a general rule, your really sick patients are going to go to which nurse or which healthcare provider, the CNA, the RN, or the LPN? RN. Your LPN is going to take care of the patient that's stable but still needs skilled nursing care. Your CNA is going to do stuff that's not, it's just a procedure. It's vital signs. It's taking them to the bathroom. It's that kind of thing. It's not going to require that they evaluate that patient to see if something's been effective. Okay? We will stop there. It is 12:15. I will lock the doors when y'all leave if y'all want to take your purses. And be back by 1:15. That'll give you an hour in case the 1:15. In case sometimes I think the baseball players are here today, so it takes a little longer to get their line. Oh, crap. It's not, but Miss Brown can give you the key. I would say I would, but then I can't lock the door. She should be in her office. So you know where the lab's at? There, like if this is the lab door, there's a door right here. Just go in there and just kind of follow around. You'll see her. She's in her office. It should be open. Okay. All we have to worry about.
I have a question. So what we're going over today, is there a certain chapter in the pharmacology book that we need to read, or do we need to just study our notes? I'm just trying to get everything in order. It's
Your notes are going to be pretty good, but I think it's like the first 6 chapters of the book.
Okay.
There may be some stuff that we don't discuss that's in those chapters, but the chapters are short.
Okay.
So I think it's either first 5 or first 6.
Okay, and just kind of review through that stuff, like as far as for testing
Yeah.
and things like
And
that.
if I didn't cover it in class, there won't be a test question on it.
Okay.
Because there's some stuff in there, like herbs and stuff, that we don't touch on a lot.
Okay. Okay. Thank you.
Mm-hmm.
You going to the Yeah. Are you going? Yeah. You got a lawnmower or something? You got the lawnmower or something? No. You going to try? Will you stacking those feet? Yeah.
Sometime today. Okay. All right, I do want to go back on the Durham-Humphrey Amendment. It is 1952. Okay? 1952. The Harris-Coffer was 1962, which is what's on the slide. Okay? All right, I think that left us off with the Substance Abuse Act, so that's what we're going to pick back up. It was established in 1970, and it does several different things, not just what's on the board, so I'm going to go over a couple more things, so I'm just going to make a little side note. It promoted drug education and research into the prevention and treatment of drug dependence. It was established because of the increased incidence of drug abuse of drugs in the general population. It helped strengthen law enforcement authority in enforcement of rules and regulations. It also established rehab and treatment facilities. But what it's most known for is it actually put the drugs into 5 schedules, which is what's on your slide. Promotion of drug education and research in prevention of drug abuse, rehab and treatment, strengthened the law enforcement authority, and then it put the drugs into different schedules based on their medical usefulness, harmfulness, and risk for abuse and addiction. Just to kind of give you how this does impact the nursing field, there's some things that we have to do that are related to this particular act. We have to account for all controlled substances. So most of this is done now with some type of computerized system. At our hospital, we use an Omnicell system where you have a certain code that you put in that system to be able to get out narcotics. And anytime it pops open a drawer that has narcotics in it, it's going to ask you to do a count. So it's counted every time that drawer is open. And you say, yes, the count's correct, or no, it's not. And if it's not correct, somebody has to witness that, and then it goes to pharmacy, and they have to do some investigation to see why the counts are off.
Does this have to do with you purchasing a drug at the drugstore, and they ask for the picture ID, and they go to the counter?
Yeah, because with a lot of the drugs that we use now, there is a high level of abuse with those, and people will come in and get other people's prescriptions and then take them themselves when they weren't prescribed to them. So that's a safety feature that's built in.
No, I'm talking about over-the-counter stuff.
No, that's not directly related to this act. You're talking about like the cold medicine and stuff. They've really kind of cracked down on that here lately. My grandmother called me in tears because my poor grandmother she's precious, okay? And she was devastated that they would not let her have her sinus medicine because she took it, every day. That was how she took it, and she was over her limit, and they wouldn't let her have it. And she said, they made me feel like a drug addict. She was devastated. So, yeah, but that's not directly related to this act, though. Alright, we do keep a special record of all required drugs, and most of your drugs that are high alert or narcotics are going to have to be kept that way. We have to co-sign all discarded or wasted meds. So let's say if I got out a vial of morphine and I was only going to give half of it, and I'm wasting the other half because my patient doesn't need it because I got to give the right dose. In order to waste that, I have to physically show it to another nurse, and she has to go into the OmniCell and say, yes, she wasted 0.5 milligrams or whatever the case may be.
What do you do with it?
Just put it in the sharps container or down the sink. Don't put it in the trash because people will go through the trash to get it. Ensure that records match. We do that. Keep controlled drugs locked up. Ensure that only authorized persons have access, so that's why you don't share your access code with anybody. Okay. Alright. There's 5 schedules of these drugs. It starts with Schedule 1 and goes through Schedule 5. Schedule 1 has a very high abuse potential, and there's no currently accepted medical use, such as LSD, heroin. Marijuana I left up here. I know that we do have some states that are allowing medicinal use of marijuana, but for the most part, it's across the board, it's still considered a street drug. So. Schedule 2 has a high abuse potential, a high risk for dependence. It's currently accepted for medical use, but it may be restricted. Telephone orders are permitted in emergency only, but a written prescription must be presented to the pharmacy within so many hours. No refills. An example of this would be morphine or Demerol. Morphine especially. Why would there ever be a case where there could be a potential for an emergency type situation where you would need to call in morphine? Well, they will be in the hospital, so that won't be an issue. Possibly surgery. Home health. Hospice. If you've got a terminal cancer patient, you're not going to sit there and say, well, I'm sorry, you can't have any morphine until Monday. Okay? So that would be one of your scenarios where you could have an emergency call in for morphine, but when the pharmacy opened back up or when the physician's office opened back up, they would have to present a written copy of the prescription. Do what now? Do we do what? Oh, yeah, most of them are. I don't know if everybody does that, but most of them do, yes. Okay, Schedule 3 has an abuse potential that's less than that of 1 or 2. Moderate to low risk of dependence. It is accepted for medical use. Telephone orders are permitted, and they can even do limited refills. Some of your barbiturates are going to fall into this category, or Tylenol with codeine. Schedule 4. A lot of this seems repetitive. Low abuse potential is compared to Schedule 3 drugs. Limited risk of dependence. It is, of course, accepted for medical use. Telephone orders are permitted. Limited refills like Xanax and Valium. And then your Schedule 5, of course, are going to have the lowest abuse potential, lowest risk for dependency. The prescriber can determine how many refills that they're going to give that particular patient, and a lot of these are actually going to fall into over-the-counter drugs, like your cough medicines and that sort of thing. Antitussives? What does that mean? Anti-cough. All right, a little bit more drug information. The Drug Relations Act was established in 1992. It increased the approval rate for drugs used to treat AIDS and cancer. Why do you think it's just those that were approved in this drug and not all drugs? Because sometimes it takes years and years and years to get a drug approved. So why would these two conditions be singled out? Because they don't have years. Yeah, they don't have years. So if there's a potential drug for a cancer patient that's terminal, then they may make the decision that they're willing to take that risk because they're terminal. Does that make sense? Okay. The Pediatric Research Equity Act was established in 2003. What this does is it requires that there's testing done to ensure safety and effectiveness in children for any drug that's being marketed for children. The FDA requires that testing be done in children to ensure safety and effectiveness if that particular drug is being marketed to kids. And that makes sense, right? We want it to be safe. Is there a reason that drug companies might not want to target a drug towards kids? Is there a reason that drug companies in the past really haven't tested in kids and haven't marketed their drugs towards kids?
Because it takes years to find out if it comes through.
Possibly because of the long-term effects. But do you really want to test medications on kids? Are parents going to be really willing to let that happen? So, right. I mean, you don't. There's very few conditions that parents are going to say, well, go ahead, my kid, you can test it on my child. So, and the other thing that you have to think about is, with an adult, regardless if they weigh 100 pounds or 150 pounds, their body system reacts generally the same way. But when you're looking at the difference between a 2-day-old, a 6-month-old, a 2-year-old, a 6-year-old, and a 12-year-old, then every one of their little body systems is going to react different because they're growing and they're maturing. So it's much more expensive to test in all those age groups. So that's why a lot of the drugs that we see used for pediatrics were not tested in pediatrics. They were tested in adults, and we may use them in pediatrics. And then they may have to go back and test for that. Okay. All right, pregnancy categories. This looks at the safety of medications related to pregnancy. Okay? So if it is a category A, like if you looked in your drug book and it said that it's a category A for pregnancy, then it's safe for pregnancy. Studies have shown no harm to the baby at all, or mom. Such as Synthroid, which is a thyroid medication, and potassium. Those are things that fall into category A. Those are safe for pregnancy. Category B, animal studies haven't shown a risk, or if they have shown a risk, human studies have shown that there is no risk. I'll repeat that. With category B, either animal studies have shown no risk to mom or baby, or if they did show a risk, then human studies have said there's not a problem. Okay? Or they haven't confirmed that. Okay? Sure. Either animal studies have not shown that there's a risk to mom or baby, or if they have, human studies have not confirmed that risk. Okay? Tylenol falls into this category. Category C, animal studies have shown some risk, but control studies have not been done in humans. Such as Lasix. Do you know what Lasix is for? It's a diuretic, which does what? Pulls fluid. Animal studies show some risk to mom or fetus, and control studies in humans have not been performed. And Lasix falls into this category. So does Zovirax. Do you know what Zovirax is for? Antiviral. So you may see some people taking it because they have fever blisters, but a lot of people take it because of herpes. It's taken daily for that. Okay. Category D, use of the drug may cause harm, but benefit to the mom may warrant that you give it anyway.
So cause harm to the fetus, benefits the mother.
But benefits the mother. Coumadin falls into this classification.
What?
Coumadin. I actually work with a lady that has seizures and found out she was pregnant, and the medication that she was on for seizures was a category D. But it was either take her off that medication and risk that she's going to have seizures. The medication itself could cause some birth defects. So that was something that she had to weigh, and she ended up staying on the medication, and the baby was fine. But that was something that her and her physician had to discuss. Category X, studies have shown significant risk to the mom or the fetus and should not be used. How many of y'all have kids? What did your mom or grandmother tell you to do to put yourself into labor? Castor oil is a category X. Because it's harmful to the baby, because what does castor oil really do? Makes you go to the bathroom. Well, guess what? And if they're in utero and they breathe in that bowel movement, they can have a lot of respiratory problems.
My son, when I had him, he had a bowel movement inside, and he came out not breathing for 45 minutes.
Yeah. And it's not always related to castor oil. Sometimes it's, sometimes it just happens, especially if you're overdue. Yeah. But I always bring that up because that's what my grandmother says. Take castor oil. I'm like, oh. It's throwing up.
I took it with my daughter, and I was so bad because I woke up and I was in labor if I had to I was in labor.
It's bad. Okay, when we look at the drug approval process, I'm not going to spend a lot of time on this, but I do want to kind of touch on it and let you know how the process works. It occurs in 4 different stages. The first one is the preclinical investigative stage, and this just involves basic science research, and then they may even do some studies in the lab on animals. So this is the basic scientific research. The lab, they'll do lab results on animals or lab testing on animals. And why do you think they did that in the first place? To see if it's safe. I mean, not that I don't like animals, but better it to be a rat than a human, right? I mean, that's the thought process. Let's test it and see how it works in an organism, and let's see if that, if there's any problems that we identify there. So that's your first stage. The second one is your clinical investigation. It usually takes place in about 3 different phases. I'm just going to kind of talk about them in general. They do clinical trials on small groups to see how that particular group responds to that treatment. This stage can take up to 10 years. So now you see why we had to speed the process up for some disease processes that needed it. So during this clinical investigation, they do human trials with small groups of individuals that they track to see how they're responding to that medication. Does that make sense? Okay. The third phase is the NDA review, and that's the new drug application. That's what that stands for, review. So basically, they take all their data and they say, this is the drug that we want to market, and here's the research and the trials. And then the FDA will say, you're approved or you're denied. If you're denied, you go back to square one or go back and tweak some things and resubmit. If you're approved, then you're going to go to stage 4. Okay? So, yes?
What was the NDA review?
New drug application. So if you're approved on stage 3, you go to stage 4. And basically what happens now is you do a clinical trial on a much larger population group. And these are known as post-marketing studies. And the reason they do this, and a lot of times this is the reason you see that drugs are withdrawn from the market, when they had that small sample group, they may not have identified that that particular drug could cause heart problems. But when they put it out in the general public, they realized that they had some issues with it causing heart problems. So then they can go back and pull that drug off the market.
So post-marketing would be like these commercials you see on TV, not approved by FDA, blah, 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 blah. Free. Call for your free sample. Is that it?
Yes. Or some of them may even be that they're doing them in doctor's office. They may say, we've got this new drug, and so, but they still follow these patients to make sure that there's not an issue. And if they see that there is, then the FDA has the ability to kind of pull that drug back in.
Does the doctor let you know that this is in the
He should. I'm not.
I remember when Prozac
Yeah. Yeah. He should say, this is a new drug. It has been FDA. It has been approved as a new drug, and we're in post-marketing studies for this, and we're going to try it and see if it works for you.
So on that.
Yeah. Okay. Okay. All right. So as far as sources where we can get drug information, clinicians like your healthcare providers, your PAs, your nurse practitioners, your MDs, your pharmacists are good resources. Most of your hospital have a wide variety of pharmacists on staff. Our hospital has one on each floor or one on 2 floors that kind of goes back and forth. So there's usually somebody there that you can ask these questions to if it's a really new drug and it's not in your drug book or something like that. Poison control centers are good resources for the public in case a patient's daughter takes her medicine by accident, that kind of thing. Pharmaceutical sales reps, I put this up here, and people always look at me funny. Here's my only disclaimer with that. That particular representative is going to tell you that his drug is the best because that's their job. But if you're looking at specific information, it's also their job to know every single thing about that drug. So they're good sources of information, but they're also going to tell you that the other competitor is not as good as theirs. So you got to take that with a grain of salt, okay? Because that's their job. But they are a wealth of information about how the drug works, that kind of thing. Okay? Publications, textbooks like your core concept book, reference books like your Davis Drug Guide, and then internet is a very good resource as long as you're using reputable sites. Don't go on Joe Blow's blog about how he took Zoloft and now he has an extra toe. Okay? You got to find those good sites. And all the drug companies, if you Google that drug, it'll take you directly to that company's official site so you can learn about that drug. Because everybody, you don't hear the good stories, right? You always hear the terrible stories. All right, medication names. The chemical name of a drug is actually the chemical name. It's long, it's hard to pronounce, and we really don't use it much. The chemist may know, but that's about it. This right here is the chemical name for Tylenol. Okay? Yeah. So just know that it exists, and we're going to move on. Okay? The generic name is usually longer than the trade name that we're going to talk about in a few minutes. But this is the form that boards is supposed to use because it is standard. So if I went to Canada, because in Canada they don't market Tylenol, they have another name for it. But if I went to the pharmacy and said I need acetaminophen, they would know exactly what I'm talking about. So this is the standard name. And it's usually cheaper than the trade name because the trade name you're actually paying for that trade. Like Tylenol is a trade name. If you go and buy Walmart brand acetaminophen, that would be generic. Same type of drug though. Okay?
So how are they, I always wondered when they came out with generic,
how that works?
how they're taking money from the trade names, how they're allowing.
Usually the company that comes up with a new drug has sole rights on that drug for 17 years. But that is, you subtract the drug process. So they may not have a full 17 years once it starts being marketed on, to the general public. So for whatever length of time that is, nobody else can use that drug. But once that is up, then other companies can compete. And a lot of times the physician will be asked if they will allow you to use a generic name. For the most part, those drugs are the same, but the chemical, how they package them and how they bind them and that kind of thing may be a little bit different. But most of the time, they'll just say, yeah, you can use the generic because it's cheaper. There's a few drugs where most physicians say, no, it's got to be the trade name.
No, my insurance company will pay for the generic name. If it's less than $10, I pay. If it's more than $10, they'll pay. But on that brand name, they only pay like $20.
Yeah. Because you're paying, it's kind of like buying a pair of jeans from Walmart versus Gap. You're going to pay more for those Gap jeans because you're paying for that label. Whereas if you're buying Walmart jeans, you're not paying for that name brand. Does that make sense? Okay, so that's the chemical name and generic name. So boards is supposed to use generic name. For my test, I will put trade and generic because trade name, it's funny because sometimes I use the trade name for drugs and sometimes I use the generic. It's just whichever one sticks in my mind. The trade name is usually shorter and easier to remember. Why do you think that is? Because that company wants you to go in and say, I got to have some Lunesta. I'm just in love with that little shiny butterfly that flies around and grants everybody sleep. That's what I want is some Lunesta. They want you to go in and say, I want this. So they want you to remember that name so that if you need that type of drug, you're like, oh, I think I want to get some Lunesta.
What's the generic name for Lunesta?
I have no idea.
What is Lunesta?
It's a sleep aid. Sleeping pill. A little butterfly. So an example of this will be Tylenol. What we are seeing a trend in is a lot more combination drugs. So don't let that trip you up. So when we go over drugs, there's a lot that they'll combine together, like diuretics and blood pressure pills because they work really well together. I don't go over a lot of combination drugs, but if you see the generic name, you'll know which two drugs are in there. So we will go over that. So just know that. What it does is it actually helps the patient because sometimes you can get them less expensive if you get one pill versus having to buy 2 pills. Plus, they only have to take 1 pill versus 2 pills. So it helps the patient. All right, let's look at some drug labels. What is the trade name of this drug? Glucophage. What is the generic name? Metformin. All right, do y'all know what kind of drug this is? It's an anti-diabetic. It's an oral agent. So what form does it come in? It's tablets. How many milligrams is each tablet? How many are in the bottle? Who made it? Okay, so we got all that information just by looking at the drug label. What about glucotrol? Trade or generic? Trade. What's the generic name? Glyphosate. What form does it come in? How much is each tablet? Good. You know what that drug's for?
All the that's the trade name. Does all of the trade names
Have the R.
underneath it? Like that one?
On the labels, probably. Usually the trade name is going to be bigger than the generic name, but you'll always know on the labels anyway, the trade name is always going to have that little circle with the R in it. Now if it's on test, I don't put the little circle on the R, you just have to know that. But yeah, if you look at the label, the trade name will always have the circle with the R, showing that it's a trademark for that company. What about this one? What is your generic name? Verapamil. Okay. What is your trade name? What do you think the SR stands for? Sustained release. Okay. How many milligrams? And what is it available in? Capsules or caplets. Okay. What does it mean when something is sustained release? Slow release. Okay. So is there anything we need to teach the patient if we're giving them medications that are slow release? Okay.
It's slow release to like time or
Time release, control release, sustain release, all mean the same thing.
They need to make sure that they don't break the capsule.
Don't break it, don't crush it, don't chew it. So y'all go ahead and write that down. Don't break it, don't cut it, don't chew it. Why would you not want to do that?
Because the layers that sustain the console.
So where you may have been supposed to get, let's say, 5 milligrams an hour, you just got 240 milligrams like that.
And also because of the enzymes and the stomach, right?
There's some enteric coated, that's a little bit different. Enteric coated means that it's got a lining over it to get it through the stomach. About the 5 milligrams I was talking about. Like let's just say, and I'm not saying that's what this is, but let's say that peel was supposed to release 5 milligrams an hour. That's how it was set to work. And you cut it. Well, basically, you just got 240 milligrams at one time. Okay? My grandfather called me. He's like, oh my gosh, this new arthritis pill is working so good for me. And I was like, oh, that's wonderful. So I always go and look at his, because I need to know what he's on in case something happens. I'm like, oh, that's a big old pill. He's like, oh, I just cut it in half. I'm like, you can't cut it in half. But that's why you're feeling so good, because you're getting all of it at one time. So if you have a patient on sustained release, control release, extended release, all those things mean the same thing. Can't be cut, crushed, or chewed. Do what?
that makes sense now with my mom and
All right. What is the trade name? And the generic name? Nifedipine. Okay. How many milligrams? And what form is it in? How many is in the bottle? Okay. So when you're doing drug calculations, it's 10 milligrams per one capsule, not 100 milligrams. That's just the number that's in the bottle. Okay. So it would be 10 milligrams per one capsule. Does anybody know what Procardia is? It is a heart drug. It is a heart drug. But does anybody know what the off-labeled use for it is? Off-labeled use. The reason we would use it, that it's not really in the drug book, is used for that. Preterm labor. We use Procardia for preterm labor. It's a smooth muscle relaxant. The uterus is a smooth muscle. I was actually on that with my last pregnancy. My blood pressure ran about 80/60, but didn't have any contractions.
So if you have, when you have like a tear, like you in your other practice, you have a tear and you like lose small amount.
Like from the placenta?
Yeah, one of my friends was doing that. I think they put her on that.
Probably not for the tear, but for the irritation to the uterus that would cause contractions. Yeah. Did she have an accident or anything?
No.
It just happened? Sometimes it just happened.
48 and got pregnant. Like you said, it's one of those things.
Yeah, sometimes it's called an abruption. I mean, I think that's what that sounds like what that's going on there. And a lot of times they'll seal themselves off, and there's not really any rhyme or reason. So we just watch it. All right, classifications of drugs. Drugs are grouped together by similar characteristics: the effect of the medication on the body, the symptoms that it relieves, the desired effect. But it's our way of kind of grouping them together so it makes more sense to us as to what that drug does. So I'm going to show you how we do that. Maybe. Okay. Okay, Tylenol. Why do we give Tylenol? For pain, which would be an analgesic. What else? Fever, which would be an antipyretic. Okay? Pyretic. Hang on, I think I got it on here. It's just really, really slow. Oh, Lord, what happened? Oh, I guess I don't have it on there. Okay.
You said analgesic.
Analgesic, A-N-A-L-G-E-S-I-C. Analgesic, for pain, what that means. And then antipyretic, so A-N-T-I-P-Y-R-E-T-I-C. Antipyretic.
And what's that?
For fever. Okay? So is there a difference in what might be going on with the patient if they're running a fever versus if you're giving it for pain? There is, right? It's not the same process. If somebody's in pain, then something's probably injured. But if they're running a fever, what's probably going on with them? Infection. So it's always really important, if you do have a drug that kind of falls within two classifications, that you actually know why you're giving it, because there's a different set of criteria for what you're going to do for somebody that's getting it for pain versus somebody that's getting it for fever. Okay? So classifications just kind of groups it together. Let's see if y'all remember. What is the most important characteristic of a drug?
No.
We talked about it earlier. What is it? Effectiveness. How effective it is. Because it could be completely selective and completely harmless, but if it's not doing what it's meant to do, then is there any purpose in taking it? If you're taking it to decrease your blood pressure, but it's not decreasing your blood pressure, then effectiveness. Okay, here's some more terms that we're going to talk about. Onset of action. What do you think that means? When it starts working. Onset of action. The time it takes after a medication is given till you actually get some benefit from it. Or you get a therapeutic effect. Sure. Onset of action. The time it takes a medication from the time of administration till the time that it starts to produce a therapeutic effect. Okay? The time it takes from the time that you administer it till it actually has a therapeutic effect. Like, for instance, if you take Tylenol, it's the time that you actually popped it in your mouth until your headache started to go away. Okay? Somebody need me to repeat it one more time? Okay? The onset of action is going to be the time frame in between when you take a medication until it starts to have a therapeutic effect, or it starts to work. Sure. The time between when you take a medication and it actually causes a therapeutic effect. So the time between when you take a medicine and it starts to work. Okay? Everybody good now? What do we say contraindication meant? You would not give that medication, or it's not advised to give that medication. Like giving heparin to somebody who just got their leg chopped off in a tragic accident. Probably not a good idea to give them heparin. They're already having bleeding issues. Drug-induced tetragenesis. Any ideas? Adverse reactions to the fetus. If a drug is tetragenic, it is damaging to a fetus. Okay?
I'm not being smart.
Drug-induced tetragenesis. So your drugs that you use for abortion are tetragenic. Those are tetragenic drugs. Okay, any questions? Moving right along. Okay, some more terms we're going to talk about. Peak effect. Where is the peak of a mountain?
The highest level.
The highest level, okay? So the peak effect of the drug is the highest blood concentration of that drug. And sometimes you'll see it listed as highest serum concentration. The word serum is going to be referring to the bloodstream. So the highest blood concentration. And if you look in your drug book or on your app, you'll see that it'll tell you in your drug book when the peak effect of that drug is. So if let me use diabetic agents as an example. One of your insulins, the peak of that insulin is an hour. So if the peak is that's when you're going to be at your highest level, right? What does insulin do? Lowers your blood sugar, right? So you know when it peaks, that's when you're most likely to see a low blood sugar because it's at its highest level in your body. Does that make sense? Okay, so that's what we use the peak levels for. We use it for judging how the patient's tolerating it, how we're going to dose them. So the peak level is the highest blood concentration. The reason we use the blood level is you can't really go, like let's say it's a CNS drug, you can't go bore in their head and get a sample out of their brain. So we use a blood level to kind of dictate our dosing. Okay? So the peak level is the highest concentration. So if the peak level of a drug is 4 hours, then you know that that's when, if you're going to see adverse effects, that's when you're going to see them most likely. And you can see them anytime, but that's when you're most likely going to see it because you've got a higher concentration in your bloodstream.
Is that when you're going to test for blood sugar also?
Not necessarily, but it is when you need to watch for signs and symptoms that their blood sugar is dropping. You may not check it after every dose during that peak time, but you're definitely going to watch for signs and symptoms of low blood sugar. Okay? Somebody know what some symptoms might be? Think about when you don't eat. What do you feel like? You feel tired and faint and shaky and irritable, and you're like, if you could just give me something to drink and something to eat. I just want something. Okay? So that's what you would monitor for. If they're in there and they're just kind of shaky, then you would know to check their blood sugar. Okay? Did you have a question?
I said when it's high, when my boy's high, he is hungry.
Mm-hmm.
I mean,
Yeah.
he needs 300, I'm thinking, you need nothing. But I'm starving, and you know he has.
Because his cells are. It's just the way diabetes works. We're not going to get into diabetes so much. We will cover some of the drugs, but there's 3 P's of diabetes, and polyphagia, which is want to eat all the time, is one of your symptoms of diabetes. So. Do what? You're hypo right now? Girl, let me give you a drink. In nursing school, we tend to promote hypoglycemia, apparently, because we keep you in here all day and don't give you a lot of breaks. Always get you something to drink and a little granola bar to keep in your pocket. I don't want y'all going. Okay. All right, so peak effect. Duration of action. How long it lasts. How long it lasts. The length of time that it produces a therapeutic effect.
Which one do you want to write?
Whichever one you can remember. They're both the same.
So like on a cold medicine or something, and the directions say it took only 4 hours. So it would actually, the medicine would actually peak at 2 hours? Is that how that would work?
Probably somewhere around there. And that's the duration of action is going to determine your dosing usually. That's why you get Tylenols every 4 hours and Advils every 6 because of the duration of action. You don't want to start compiling that. If your duration of action for Tylenol was 5 hours and you were giving it every 3 to 4, then you would have some compiling of that medicine. You could get in some trouble. All right, plateau. What does the word plateau mean? Flat. Okay. So plateau basically means that you get a pretty constant blood concentration of a drug with repeated doses. Okay? So if you give antibiotics is a good example of this. You give antibiotics and you give them every, let's say, 8 hours. And what you're wanting to do is to keep that blood concentration within that therapeutic range. You don't want it to go up in the toxic range or down below where it's not working. You want it in that range. So we call that a plateau effect.
That was the constant blood concentration.
After repeated doses of the medication. And your antibiotics is a good example of that.
What does that mean?
Plateau just means a constant blood concentration level after repeated doses of a medication. So these are ones that you're going to give every 6 hours or every 8 hours or whatever because you're wanting that concentration to stay pretty level. Okay. What is a trough? Okay. What do pigs eat out of? Where is it? On the ground, right?
Low range effectiveness.
The low end of effectiveness. So if this is the highest level, this is the lowest level. Okay. So trough is the lowest blood concentration of the drug. When do you think, I'm going to let y'all write and I'm going to ask y'all. Okay. When do you think you will have the lowest level of a drug? Right after you give it or right before you give it? Right before. Okay? let's say you had a dose of antibiotic at midnight, then before they hung that 8 o'clock dose, they would draw a trough level. Okay, because of your duration of action, that's when it should be its lowest. So in a lot of your antibiotics, you'll see them do troughs and peaks. They want to know what's the level when it's at its lowest and what's the level when it's at its highest. Because we want it to be enough to be effective, but we don't want it to be too much that it's toxic. You with that? Any questions? You're all overwhelmed? The reason we don't do peaks and troughs on a lot of drugs, but your antibiotics we do, or some of them, like vancomycin, gentamicin, the really high-powered antibiotics, we do peaks and troughs on. And we'll talk more about that when we talk about those specific drugs. Okay. So here's your nice little picture. It kind of pulls all this stuff together. I'm very visual, so I like to look at pictures. So basically, this is when the dose was given. This would be your onset of action, because if you look at this, if it's below this little dotted line, it means there's not enough in your bloodstream to elicit a reaction. If it's above this dotted line, it's toxic. Okay? And depending on the drug, there may be a small area or a larger area. It just depends on the drug. So if this is when it was administered, here's your onset of action. Peak. Your trough's going to actually be more down here, even though, so you may not be getting a response. So this right here is your duration of action. If you gave several doses, you would see that this line would kind of go up and you'd stay within that therapeutic range.
Well, what is it when it leaks into the onset, like
Here, go down. This just means there's still some of that drug left in your body, but it's not enough to make your headache stay away. That makes sense? There's still some left, but it's not enough to get the response that we're wanting. Okay? So we'll do that. So onset, peak, here's your duration. And I do want you to be familiar with these terms. The minimum effective concentration. Okay? It has to be above that line to elicit a response. So minimum effective concentration. If this is the minimum effectiveness, what would this line right here be? Maximum. Okay? So the space between your minimum effectiveness and your maximum effectiveness is your therapeutic range. And that's where you want it to be.
level is where the medication is going to work the most? Like
Yes, it's going to work the best.
But if it's above that, then
It can cause problems. Let me give you an example. Let's talk about, I've been mentioning antibiotics, okay? If your antibiotic level is down here, is it doing you any good?
no.
Is it toxic to you?
No.
No. But is there a problem with it being subtherapeutic? And sub means below, right, like a submarine? So if something is subtherapeutic, it's below that therapeutic range. So if it's down here with an antibiotic, that's bad too. Because there's not enough to fight the infection, and you're actually just giving that bacteria enough to become resistant. So that's why you take all your antibiotics so they're completely gone. So subtherapeutic is not toxic, it's not working for you. Once it reaches this and goes over, then it becomes toxic to the body.
So I'm sorry, I have a question.
That's fine.
How do you know, like, as far as, like, 'cause you're not being monitored in a hospital, like, how do you know if it's going above your peak level? Like, if a doctor were to prescribe antibiotics.
Right. A lot of the antibiotics have a wide therapeutic range, so the likelihood that it's going to become toxic is slim. And we know how a person's body normally reacts to that. Now, there are some conditions that would cause us to be a little bit more mindful, like if they had kidney failure, they wouldn't be on what I would take as an adult dose. They would be on a smaller dose because their kidneys are not going to clear it. When it becomes a problem is with your high-powered antibiotics like your gentamicin and your vancomycin, and they do peaks and troughs on that drug to make sure that it doesn't go above that. Like with vancomycin, it can be ototoxic and it can be toxic to the kidney, so it can cause hearing problems and kidney problems. So they monitor it usually every other to every third dose to make sure that they're keeping it within the therapeutic range, but they're not getting too high.
So the maximum effective concentration is right below the top.
Right. It's the top level that you could be at and still be considered therapeutic. Okay? And I know I'm throwing a lot of terms at y'all, but I promise it'll kind of come together, but it's just terms, and it's just something you're going to have to kind of review. Any questions about this? Are y'all good with this? Okay. I don't know if y'all are just full like me and I'm just like... Okay. We're fixing to start pharmacokinetics. Do y'all want to take a bathroom break before I do this? Because this gets kind of deep. Okay. It is it's about 10 after 2, so be back by 2:25.
It's only for the SUSCC challenge.
I'm going to put that out there.
Do you see? Would you think this space could do anything like that?
I know.
I'm paying my tuition and everything. I don't get email. So what I'm trying to do is I'm trying to use my daughter's iPod. Is that possible? So is it? We
Yeah.
can do that.
Oh, yeah. That's fine.
And I'll just have a code to get in. So if I tell her not to do, she wouldn't. But just to be
No,
safe.
I mean, it's fine. If you're using it, like if she's using it as her iPod during the weekend, that's fine. The only time that we're concerned about is when you have it and you're in clinical. So, she can, just fine. Because there's nothing that's like patient sensitive on there. So even if she wanted to go onto your apps and look up drugs, that's fine. Yeah, you don't have to worry about it. Yeah.
That's what she was just talking about.
Yes.
That's what they want to test.
Yes, that's on the first test.
So what would be, like a question, how would you,